Yes, good afternoon. It is my great pleasure to introduce Dr. Ben Anderson for today's lecture, and we're all looking forward to hear about esketamine. Dr. Anderson finished his medical studies at initially University of British Columbia and then subsequently St. George's University. Prior to that, he was volunteering as a teacher in Tanzania. Subsequent to his medical school, he then went on to do a residency in general psychiatry and then fellowship at George Washington University at Children's National Medical Center. He then came to the Institute of Living in 2017. He joined the team in child and adolescent psychiatry and worked primarily in the emergency room and CCMC and then consultation liaison. Subsequent to that, in 2019, he kind of switched over to the adult world and joined the emergency room team. And we were very lucky to have him join our Center for Interventional Psychiatry, to have him lead the opening of esketamine clinic. This was a very long process. And despite numerous obstacles and challenges, Ben really has been able to overcome all of this and help us create this very important clinic for the Institute of Living and Hartford Healthcare. We are the only place in Hartford Healthcare that has this clinic. It was a long process with countless meetings that Ben was in charge of with pharmacies and setting up our website and staffing, and together with Christine Burby, our manager for the center, and Cassandra De Monte, they really have done a lot of work to open the clinic. And then, of course, COVID came, which was another slowdown to this process. But I do have to say that he never lost his enthusiasm to really accomplish this task and bring us to where we are today, talking about our esketamine clinic and also the esketamine treatment that is now available to our patients. And I just can't say enough how grateful I am personally to Ben for all of his efforts and everything he has done. And the Institute of Living and BHN is also very grateful for all of this. And we're looking forward to this wonderful talk. Thank you.
Thank you very much, Dr. Fogg. Thank you so much for introducing me and also just for your support in this long process. Of course, I'd also like to very much thank Christine, our nurse, and the nurse that I work with in clinic, Cassandra, who's terrific. So I'm just going to back up the slides a little bit. Dr. Dewberry asked me to prepare a talk on this topic. This was a couple months ago. Some of the purpose was to introduce our clinical service that we have here, as it is a new service, and also to kind of introduce the treatment itself. So hopefully my aims for today are to help you, my colleagues, understand kind of what we do here, who to refer, and in explaining this, I hope to be able to answer some of the most common questions that come up when thinking about this treatment. I personally have no financial disclosures to mention. When looking at the schedule, when I was coming up with the schedule, I thought of just kind of what are the big questions that people want answered. And a lot of these were the questions that I had, 2.5 years ago when we started this kind of process in 2019. So these were a lot of questions that I had when I got started, and these are questions that I still get today. And so by going through answering these questions, I'm hoping that, you guys will be able to gain some understanding about what this treatment is about. At the end, there'll be an opportunity to ask any questions you may have. So I'm going to start by just very briefly looking at, is this a treatment that's needed? And then from there, pivoting to kind of look at the historical context. Where did this medication come from? When did it start to get used in depression? From there, going, how does this medicine work? Just reviewing kind of the brief kind of pharmacodynamics and pharmacokinetics, side effects, and then how we think it might work for depression. And then trying to answer the question is, does it work? Is it effective? Looking at some of the research that's involved. And then finally, just kind of going through our treatment protocol that we have here. What does treatment actually look like? And just giving a brief perspective on the limited experience that I've had so far. So the first question is, I think definitely the easiest to answer is, what is the need? I mean, I think depression, I'm going to kind of skim through this slide because I think a lot of us know some of these numbers, but it's a huge global health problem, 300 million worldwide, 17 million in the United States. Over 2 million in the United States have what's considered to be treatment-resistant depression. And I'll take a minute to just sort of review that because it's a term that's going to come up a lot over the next 45, 50 minutes. So the consensus definition of treatment-resistant depression, sometimes we refer to as TRD, just to keep it short, is just continued depressive symptoms in the moderate to severe range that continue despite adequate trials of at least 2 antidepressant medication trials of adequate dose and duration within a current episode. So it's a term you'll hear continually through the next little while. As we know, depression affects all aspects of our lives: eating, sleeping, energy level, self-worth, desire to live. Many patients with depression support the inability to function in their lives. It's a major cause of disability in this country and throughout the world. It worsens the outcomes of other general medical and mental conditions, and there's a significant reduction in life expectancy. And I think, when you're thinking of kind of treatment-resistant depression, I think a useful study to refer to is a paper that many of us are familiar with, which was the STAR-D trial, which was in 2006. And this, I think, can be helpful to think about the kind of current way that we manage depression, or how we had been. And this was a pretty famous study for a lot of reasons. It was large scale. It was kind of thought to be a more practical clinical trial looking at kind of real world patients with less exclusion criteria. But basically, it was trying to look at what are the alternatives for patients that you're treating with depression who do not respond sufficiently to a first oral antidepressant medicine. So the algorithm I kind of included here. So you sort of start at level 1, with a depressed patient, you start them on Celexa. And then if that works, great. If not, what are your options? And they sort of go through these different levels of things you can do. And the choices that you make are choices that many of us that work in outpatient psychiatry are doing every day. And so this is kind of, maybe switching to an antidepressant within the same class or a different class, or augmenting with an antidepressant of a different class or a different medication, or the addition of therapy. And then you can kind of move sequentially to different levels to try to alleviate symptoms. And when you're looking at these levels and looking at, who kind of responds, I think it's, for me, and related to this talk, is thinking about, what are these kind of remission rates that we're looking at with current treatment. So if you're looking at the take home from this study was in the remission rates with the level 1, let's say the citalopram was about, a little over a third of patients experienced a remission. Once you got, if that was did not show an improvement, you would kind of go to the second level, and then your remission rates went down to about 30%. Once you got to the kind of third and fourth step, you're looking at a much lower response and remission rate, kind of 13% roughly. And really, this is the kind of TRD or treatment-resistant population that many of us deal with. And as you would expect, when you're sort of looking at these kind of remission rates, it sort of has an inverse relationship with the relapse rate. So the patients that are less likely to remit to the medication treatments are the ones that have higher risks of relapse. So the likelihood of remission definitely decreases the further along you go in the algorithm. When you're looking at, depression versus treatment-resistant depression, the TRD group has more comorbidities, medical like hypertension, diabetes, heart failure, twice the rate of hospitalizations, longer length of stay in psychiatric hospitals, a 7-fold increase in suicide rate. And so in addition to these kind of low remission and response rates and the high relapse rates, the current antidepressant medications, do take, 5 to 7 weeks to see an effect if they are going to help. And the current medications primarily target the monoamines. And when I say monoamines, I mean primarily serotonin, dopamine, and norepinephrine, which are obviously highly involved in depression, but are not necessarily the whole picture. So the short answer to the first one, I think, is the most obvious, is what is the need? I mean, there definitely is a need for new and additional treatments for depression. Another question that I had and that I still get is, so how did this medicine come to be used for depression? And I think before we touch on ketamine itself, I think we just want to briefly look at its precursor, which was phencyclidine, because there's have a similar mechanism of action. So phencyclidine first was synthesized in the 1940s. It was noted to have a calming effect on animals. And it started actually clinical trials to be used as an anesthetic, but they found that the human subjects were exhibiting bizarre behavior, confusion, delirium, hallucinations, appearing psychotic, violent. So it never became approved by the FDA. But then, about 15 or 20 years later, in 1962, ketamine was synthesized by a chemist here in the United States at Wayne State University in 1962, and it was first tested on animals and then on humans, and they found that it was a fast-acting medication with had less of that toxic behavior compared to the phencyclidine. So this one actually did go through the clinical trials, and then in the 1970s, the FDA approved it for anesthesia. And it had some benefits, and some of these benefits included that at therapeutic doses, you would have less of the cardiopulmonary depression. Your airway reflexes would be preserved. It could induce bronchodilation. And so it could be helpful in patients with hypotension or with airway disease. Over the 20 years after the approval, there was some of the behavioral effects or psychoactive effects were things that people started to abuse. You started to see kind of recreational use. It became kind of a well-known party drug, which led, in 1999, it became a Schedule III controlled substance. How it was used in depression was about in the 1990s, and it was kind of an incidental finding here in Connecticut at Yale University, where they found patients with depression who were getting ketamine and then reported that their depression was improved. And so that was a pattern that was picked up there. And then that started kind of a wave of research. And they've looked at ketamine, primarily IV ketamine, and that started to show kind of efficacy pretty quickly. And you started to see off-label use in depression in the 2000s. And they looked at, racemic ketamine, but also both an anti-MERS esketamine, which we have here and we'll get to, and then the other stereoisomer, the R-ketamine, looking at kind of for depression, primarily IV or intranasal administration. In 2017, the phase 3 clinical trials were completed for intranasal esketamine for the use, and in March of 2019, the FDA approved intranasal esketamine for adults with treatment-resistant depression to be taken in conjunction with an oral antidepressant. A year later, it was approved, the FDA approved intranasal esketamine to reduce depressive symptoms in adults with major depressive disorder and acute suicidal ideation or behavior, again, in conjunction with an oral antidepressant. So it was in this March of 2019 timeframe that we started having conversations here about getting esketamine going at the Institute of Living. And as Dr. Fogg mentioned, it took some time to get there. Part of that was coronavirus, part of that was it was initially something that wasn't well covered by insurance companies, but those things have improved more recently. another question kind of going from kind of where the medicine came from, I think a question that I had and that I get is, how does this work? How does it work in general? How does it work for depression? And I think before we get into a brief review of the mechanism, I want to, just look at just a little bit of background. So, glutamate is, we talked about the monoamines as being involved in depression, and glutamate is an amino acid, an excitatory neurotransmitter in our bodies that is also implicated in depression, and that's sort of how this medicine we think helps depression. So it's an excitatory neurotransmitter, meaning that it generates an action potential, and it binds primarily to three receptors in our nervous systems: the NMDA receptor, the AMPA receptor, and the canaic acid receptor. And if you look here, how the glutamate transmission kind of works is that, glutamate will be released into the synapse, and it will bind both the NMDA receptor here and the AMPA receptor here. So as it binds your Ampa receptor, it allows for the influx of sodium from the extracellular space into the neuron. And as sodium enters, it brings with it a positive charge that starts a depolarization. As the depolarization happens, these sodium cations displace magnesium from the NMDA receptor. So if you look at this example here, you'll see this is your NMDA receptor here, glutamate binds here, and you have the magnesium sitting there. So even if glutamate is bound to it, the ions cannot flow through. However, once you get that positive charge, the magnesium is displaced here. Once the magnesium gets displaced, you have an influx of sodium cations through the NMDA receptor, but also calcium cations as well, which have a stronger positive charge. And this leads to a depolarization and the generation of an action potential with glutamate release into the synapse. And I just included this slide because I, kind of needed a refresher of this stuff because it's been a while. But when I talk about, if you're interested, if the space in the neuron is sitting at negative 70 millivolts, the influx of these cations cause these excitatory postsynaptic potentials, so little bumps in your positive charge. And then once you get to that threshold, which is kind of here, which is generally around negative 55, you generate that action potential, which causes depolarization of your of the neuron at this isolated location, but that propagates actually throughout the neuron, and that's where you see you'll see glutamate release at the synapses. So that's the kind of background of how glutamate transmission works. Now, the pharmacodynamics of ketamine. So how does ketamine work in this system? So ketamine is a non-competitive antagonist of the NMDA receptor. So, and it's this blockade of the NMDA receptor that's responsible for the kind of anesthetic and the analgesic effects of ketamine. So basically what it does is actually enters the kind of activated NMDA receptor channel and it blocks it. So it does not allow for the passage. So if you look at the NMDA receptor, this is how it functions here. Typically you have sodium and calcium coming in, you have potassium going out, and then ketamine actually sits there and blocks the passage. So you do not have the movement of these positive charges. It does not lead to the depolarization, which does not generate an action potential and does not lead to that glutamate release, which basically causes a neuroinhibition and anesthesia at high doses. And just to mention, we talk about ketamine, kind of racemic ketamine I'm referring to, and then the Esketamine, which is the stereoisomer that we have in our clinic, is thought to be kind of having a higher affinity compared to the R-ketamine isomer for the NMDA receptors, which is thought to maybe have less of the kind of psychotomimetic effects or drowsiness or the cognitive effects. So I wanted to mention that. That's how ketamine generally works. So then the question that I had and that I still get is, how does it work for depression? And the reality is that we don't actually know. There's a number of kind of postulated theories on how it may or may not work. One of them is that the thinking that the kind of low dose of ketamine actually causes a blockade on the inhibitory GABAergic neurons. So you can see from this schematic here. And this, because you're inhibiting here, allows, because you're inhibiting here, pardon me, of the inhibitory neuron, it allows for more glutamate release, which then leads to higher glutamate being released into the intracellular space, or into the synaptic space, pardon me, and allows for more triggering of your Ampa receptors and facilitates more glutamate transmission. So that's how they think part of it works. There's also the role of generating what are called these kind of intracellular signaling cascades that I want to mention, which are also implicated in the improvement of depressive symptoms. So this includes things I've listed here, some of which are included in this drawing, in this cartoon here, which is kind of the upregulation of BDNF, or brain-derived neurotrophic factor, the deactivation of glycogen synthase kinase 3, the inhibition of phosphorylation of eukaryotic elongation factor 2 kinase, and then a big one is the activation of mTOR, the mammalian target of rapamycin. And these intracellular signaling cascades are thought to lead to an increase in what's called neuroplasticity, which is sort of one way to describe as the ability of the brain to kind of form and reorganize the synaptic connections between neurons. And that can be seen in things like, synaptogenesis, the generation of new connections between neurons, but also synaptic potentiation, which is kind of the idea that the synaptic connections between neurons become stronger with frequent activation. So these are the ways that we think it helps the depressive symptoms. Now, ketamine itself, working on the Ampa and NMDA receptors is part of the story. There are other targets worth mentioning, and these may help explain its role in depression and can also maybe explain some of the side effects. But again, these are at this point kind of hypothetical and postulated, and the clinical significance of these remains unclear, but I just wanted to touch on some of them because I think it does illustrate that ketamine is a complicated medicine that works in various systems. So I broke it down into kind of different systems, right? So there's the glutamate system. So we talked about, blockade of the NMDA receptor, and this can help with depression, but is also thought to be able to help with kind of the pro-cognitive effects, similar to medications like Namenda used in Alzheimer's, and is also thought to lead to some of the dissociative effects. We mentioned the Ampa indirect agonism, increasing your glutamate can lead to antidepressant effects. And this ties directly to the increased glutamate, which is implicated in depression, like serotonin and others, helps with depression. It also works on your opioid system. It's a weak agonist of your mu opioid receptor, which is thought to help with depression. Also can help with analgesic effect. Ketamine is something that's also kind of looked at for pain, and has a potential role for a possible acute euphoric effect. Similar to a lot of our antidepressant meds, it works on the monoamines as well. So it's a weak inhibitor of your serotonin, norepinephrine, and dopamine transporter, all of which can lead to antidepressant effect. It's an agonist of the D2 receptor, which can explain some of the acute psychotomimetic effects that are thought to be involved. And then it's a weak antagonist of your serotonin HT3 receptor, which can help, is thought to help with depression. It also works on your cholinergic system. So it can work as acts as a cholinesterase inhibitor, which is thought to help have some pro-cognitive effects. And that can sort of thought to be a similar mechanism as other cholinesterase inhibitors, like used in dementia, like Aricept and others. It's an antagonist of the alpha-7 nicotinic receptor, thought to be involved in depression. Also blocking your muscarinic receptors, which can lead to an increase in blood pressure and heart rate. Other areas that ketamine is involved with is it's an agonist of your alpha-1 receptor and your alpha-2 receptor. Both of these have kind of conflicting cardiac effects, and alpha-1 being a sympathomimetic effect and your alpha-2 receptor being sympatholytic, and also thought to have a role in depression. Again, we touched on this before, but the mTOR downstream activation is thought to be involved with depression. The BDNF has, both antidepressant, but also pro-cognitive effects, as you might expect. It's an agonist at the GABA receptor, which can explain some acute anxiolytic effects similar to, like a benzo. And then we talked about the mTOR activation being involved with kind of neuroplastic effects. The pharmacokinetics of ketamine, it comes in a lot of different formulations, IV, intramuscular, intranasal, oral. In terms of use in depression, the most common routes are the intravenous and the intranasal. So obviously intravenous has a very high bioavailability. The dose of IV ketamine used in depression is about 0.5 to 1 milligram per kilogram infusions over 40 to 60 minutes that are given twice weekly. Intramuscular has a less bioavailability, not a lot known in terms of how that helps with depression. And then the intranasal, which we have here, has a lower bioavailability. The dose ranges between 56 to 84 milligrams. It starts twice weekly. And the Tmax, the time to reach the peak serum concentration is about 40 minutes. And oral ketamine, again, a lower bioavailability, and the dosing is variable. In terms of, the half-life is about 2 to 4 hours for racemic ketamine, maybe closer to 5 hours for esketamine. It is a plasma protein binding, about 10 to 15%. It's a lipophilic chemical structure. It's metabolized through the cytochrome P450 enzyme system, specifically the 3A4 and 2D6. And so it's broken down first to norketamine, then to hydroxynorketamine, then to dehydroxynorketamine, and then is excreted primarily in your urine. And doses adjustments are not needed for weight or for liver impairment. This is a time just to mention adverse effects that you can see from the use of ketamine, and I'll later talk about the ones that I've seen in my work. But things like sedation, lethargy, dissociation, and nausea, vomiting, dizziness, vertigo, headache, transient increase in blood pressure, dysgeusia, hypoesthesia, anxiety, a sense of feeling intoxicated or altered, and sometimes cystitis. So another question I want to answer is, the patient selection piece, right? So, who is this medication for? And I think the FDA guidelines, it's approved by the FDA for adults age 18 to 64. For patients that are currently on an oral antidepressant, because it's approved as an adjunct, for a diagnosis of DSM-5 diagnosis of major depressive disorder, and that fit into that category of treatment-resistant depression, like we talked about, which is, continued depressive symptoms, moderate to severe range, despite trials of at least 2 antidepressant medications of adequate dose and duration within the current episode. And so that's who it's approved for, and that's basically who we treat here in our clinic here. I mean, occasionally we flex a little bit on the age, the upper end of the age, because that was also studied. It wasn't FDA approved, but it was seen in patients older than 65 and found to be safe and would see a clinically meaningful improvement, but it didn't separate from placebo, so it was not approved, but it can be helpful there too. I did want to mention briefly the MADRS because it's something that in the next chunk of this presentation you'll hear a lot, and it's it's the Montgomery-Åsberg Depression Rating Scale, or MADRS as it's usually called. It's a very useful tool in assessing kind of depressive symptoms, and it's probably, I think it's definitely the most common rating scale seen in ketamine and esketamine research. And it's something that we use in our clinic, so I hear it a lot. So I just wanted to touch on that. It's been around since the 1970s. It's a 10-item questionnaire, and it's a good way to identify kind of symptom severity. It has a structured interview guide, which I included on the slide, although I know you can't see it very closely, but you can find it online easily. And it's got very high inter-rater reliability. And so things that are nice about it is there's ways to kind of look at, and it's a 10 questions. Each score is 0 to 6. So the higher the score, the more depressive symptoms you have. So you could have anywhere from 0 to 60 would be your score. And so you can kind of see on this side, where you can sort of break down to look at kind of severe depressive symptoms versus moderate versus mild. And then I did want to touch on the different types of ways we can explain people's response to medication or severity of symptoms. So in the ketamine research world, they'll talk about, a stable response. And when they say stable response, that is what they're referring to is a 50%, at least a 50% reduction in a MADRS score over a 2-week time span. And then another term that you'll hear is kind of stable remission. So when we say stable remission, we mean a MADRS score equal to or less than 12 for 3 of the last 4 weeks. When you look at somebody who is a non-responder to treatment, this is something in the research world they said would be a less than 25% reduction in the MADRS change, a less than 25% reduction in MADRS from baseline to 4-week assessment, let's say, and a total score above 28. And then a relapse would be sort of explained as a score above 20, someone that previously was in a stable response or stable remission, but then had a score above 22 for 2 consecutive assessments. So when I touch on the research piece and also just touch on our clinic and our experience, you'll hear terms like this, and this is what I'm referring to. Another thing you'll hear briefly, I just wanted to touch on this very quickly, is kind of when you're thinking of the TRD group and who is treatment resistant, a lot of that is, as the definition states, is defined by medication trials. And so sometimes insurance companies will request, but also in research in terms of determining who has what's an adequate trial, there's a Mass General Hospital antidepressant treatment response questionnaire, which again you can find online, and it's patients fill it out themselves, and it looks at what medications you've taken and at what dose and for how long. And if you zoom in a little bit, you can see an example of the TCAs, kind of each one, what dose you were on and for how long. And this can be helpful to in terms of if you're doing research, to make sure that everyone's had an adequate dose and duration of a trial. But insurance companies, we've had experience where they actually want this used as well to assess whether it's been adequate. Touching base on kind of the contraindications, and this, psychosis, I don't think is quite a contraindication, but it definitely is a warning, because there is thought to be psychotomimetic properties of the medication. So patients that have been psychotic are typically excluded from the clinical trials and are not considered to be appropriate for treatment. Patients with an active substance use disorder, again, I think is something you want to be very cautious of. This is a medicine that has abuse potential. It's a Schedule III medication. There's steps that we've taken and that are mandated by the FDA to mitigate that, and I'll get to that. But I think somebody with an active substance use disorders, you want to be careful about. Anybody obviously with a hypersensitivity to ketamine or esketamine would not be a good patient to start. If you do have a patient with a history of intracerebral hemorrhages or aneurysms or arteriovascular malformations, this would be a contraindication. And again, I think this is kind of the sympathomimetic effect of the medication. It does cause a temporary increase in your blood pressure, which can become obviously problematic in a more fragile cardiovascular system and have more potential for danger. Anybody with real liver disease, also I think affecting the metabolism. Anybody that's pregnant or breastfeeding, the safety is really not known. There's no good data on that. But really anybody with any unstable medical condition. Pivoting next, what I think I wanted to discuss a little bit is kind of, does the medication work? And there is, there's a lot of research out there to suggest that it does work. And I chose to try to focus specifically on esketamine because that's what we have here, not just kind of racemic ketamine. The esketamine stuff that probably is the most well-known are the kind of phase 3 clinical trials that preceded the FDA approval. So I've kind of highlighted them here. There was 3 short-term kind of 4-week studies where they, all of which were double-blind and active controlled, all of which were measuring kind of MADRS, at baseline and then throughout and at 4 weeks to look at the change and to see if there was an improvement. And then there's 2 longer-term studies, maintenance and relapse prevention study, and then a maintenance and safety study. In the interest of time, I was going to just focus on the 2 that ended up actually in the label. So I'm going to look at one of the short-term studies and then one of the longer-term studies, just very briefly. So the short-term study I want to talk about, I have the information here. If you want to get more detail on it, you can look it up. It was a randomized double-blind study of flexibly dosed intranasal esketamine plus an oral antidepressant compared to an active control for TRD patients. When you're looking at the inclusion and exclusion criteria, some of it is, I won't go through all of it, but it's kind of what we talked about, right? So patients 18 to 64 years of age with a DSM diagnosis of major depressive disorder without psychosis, that a non-response to somewhere between 1 to 5 oral antidepressants in the current episode, they've got no history of any psychotic illness, any autism spectrum disorder, intellectual disability, personality disorders, uncontrolled hypertension, seizures, homicidal, suicidal thoughts, and a substance use disorder or a urine test showing a substance use disorder. So in the short-term study, I'm just going to go through this one a little bit. So we talked about the eligibility. So a diagnosis of MDD, a non-response, a documented non-response, and they actually use this Mass General antidepressant treatment response questionnaire so you had to have less than a 25% improvement to somewhere between 1 to 5 antidepressants in this current episode. And they needed to be taking a new or a different oral antidepressant for at least 2 weeks at or above the minimum therapeutic dose. And so that's how you got in. Once you were in, you entered the kind of screening or prospective phase for here. So this was 4 weeks. So those patients would stay on that new oral antidepressant that they were on for at least 4 weeks. And then at the end of 4 weeks, they were assessed to whether they were responders or non-responders. The non-responders, which we would define, as I did earlier, that with a MADRS of above 28 and less than a 25% change on their score over 4 weeks, were randomized to either get esketamine nasal spray, either 56 or 84 milligrams with a new oral antidepressant, or a placebo with a new oral antidepressant. And they started the double-blind induction phase was 4 weeks long. Everybody started at 56 milligrams, and then they could flexibly change up to 84 milligrams if the medicine was tolerated. And then they would assess using the MADRS kind of at baseline, and then on kind of day 2, day 8, day 15, day 22, and day 28. So basically once a week. And then looking at whether people responded, how many did, how many didn't, and then they could move beyond that, but we'll get to that shortly. So again, this we sort of touched on already, just to mention that it was a multi-center study that was done at 39 sites. And basically everything else I kind of already reviewed. Just to mention that at the end of the treatment period, about 2/3 of the patients had actually worked their way up to the 84 milligram dose compared to 1/3 remaining on 56. And that there was 223 patients were randomized 1-to-1 ratio, 114 in the esketamine group, and then the 109 in the placebo group. And so what they were hoping to look at was the change, the primary endpoint was the change from baseline from day 1 to day 28 in the MADRS total score. So that was the primary thing they wanted to look at. And then the secondary endpoint was looking at kind of a proportion of patients that showed a response by day 2, and if that was maintained for the duration of the double-blind phase. Other things they wanted to look at was how many patients showed a clinical response. Again, as we talked about, that's a 50% reduction in the baseline MADRS score. And then how many patients were in remission, meaning they had a score equal to or less than 12 by day 28. So if you look at the primary endpoint, when they compared the MADRS scores between the treatment group and the active control group, both groups did see a decline in MADRS scores, which you can sort of see here. But the least mean squares difference was between 4 points between the two groups by the day 28. And that was found to be both clinically meaningful and statistically significant. And then the other thing they wanted to look at is how many patients actually showed kind of a response versus remission. So they did find that a greater proportion of patients treated with the esketamine demonstrated a response and were in remission after 4 weeks compared to those in the placebo. So they found that about roughly 70% of patients had showed a clinical response, and within that, almost 2/3 of that 70% were actually in remission. They also looked at side effects or treatment emergent adverse effects, so things people experience. And so I included some of them here in looking at both the treatment group and the placebo group. And so things like nausea, a lot of these are things I already touched on. So nausea, and it's ranked from kind of most common to less common. So nausea, vertigo, dysgeusia, dissociation, dizziness, headache, somnolence, blurry vision, paresthesias, and anxiety. Another thing that was looked at here that I wanted to mention is they specifically tried to look at the dissociative effects and the perceptual effects in patients that got this medication. And they did this by using the CADS, or the Clinician Administered Dissociative Symptoms Scale. And they found that symptoms of dissociation peaked around 40 minutes, which coincides with the Tmax, and had resolved by about 90 minutes and tended to lessen with repeated dosing. So for example, the mean 40-minute score on day 1 was something like a 7.8. And then by day 25, it was down to about 3.5. They did not find anybody exhibiting any symptoms of psychosis related to the medication. They also found that there was a transient blood pressure increase post-dose, and this also peaked around 40 minutes, and then would return to the pre-dose range by about an hour and a half. And they looked at kind of when patients were ready to leave after getting the treatment. And so they used what's called the Global Assessment of Discharge Readiness scale. And so this kind of looks at patients' overall status, things like sedation, blood pressure, other side effects, and determines who's ready to go and when. They looked at patients an hour after getting the treatment compared to an hour and a half. And they found in the treatment group, only about 44% were ready to leave an hour after the treatment because of side effects, compared to 93% after about an hour and a half. So the conclusions that were made for this study, where the authors found, was that, esketamine nasal spray at either dose, or flexible dosing plus a newly initiated antidepressant did show a statistically significant improvement in depressive symptoms when you're comparing to a placebo nasal spray. And they assessed this by looking at changes in total MADRS score over 4 weeks in adult patients with treatment-resistant depression. And they found that it was generally, a safe and tolerable medication, and that people that had side effects experienced them typically the day of, and usually only lasted, maybe about 90 minutes. Yeah, we're good. So from here, I wanted to just talk briefly about one longer term study that I thought would be important to mention. And so the information is listed here if you want to go look it up for more detail, because obviously I'm not able to get into too much detail with these. But it was a maintenance and relapse prevention study, because patients often will ask, how long will I be on this medication? And I have those same questions still. So the objectives for this one was to look at, in patients that have improved with this medication, can that improvement be sustained after kind of, let's say, 4 months of treatment? And so the patients could get into this study either through kind of direct entry or transfer entry, and I'll get into that shortly. And it would continue until a predetermined number of relapses occurred. The inclusion and exclusion criteria. So I'm not going to go through them again. It's identical to the first group, except it allows for people entering through a transfer entry, which I'll get to. So this is kind of the general study design. So the direct entry patients were basically screened and the exact same way as the short-term study. So it was, a patient with non-response to between 1 and 5 antidepressants, as dictated by kind of a less than a 25% improvement on that Mass General Response Questionnaire, and they were on a new oral antidepressant. And then they entered exactly the same. They entered the screening and observation phase, and they continued that medicine for 4 weeks, the new medication, and then were assessed at the end of those 4 weeks. And if they were considered in that non-responding category that we talked about earlier, they were allowed to continue. And so basically, once the non-responders were entered, they were all treated with with esketamine, 56 or 84 milligrams, plus a new oral antidepressant, which was either duloxetine, escitalopram, sertraline, or Effexor XR for 4 weeks. And then, so that's one way to get in. The other way to get in was a transfer entry. So these are patients, like, let's say from the study that we just talked about, who had shown either a stable response or a stable remission. They could enter the study that way. The patients that showed a response entered this kind of optimization phase. So this kind of optimization phase kind of starts here. This was 12 weeks. So you had the initial 4 weeks and then a subsequent 12 weeks. And we were on the same dose of the esketamine and the oral antidepressant. And the frequency decreased from twice a week down to weekly for 4 weeks. And then you could be more flexible, either continuing weekly or going to every other week. At week 16, you were, the stable remitters and the stable responders who are listed here. And just to give you some background, it was something like there was, I think, 700 patients with treatment-resistant depression were enrolled. 500 or 450 or so entered that optimization phase here, and then 297 achieved the stable remission response, and so we're in kind of this group here. So this group was then randomized to either continue the esketamine nasal spray and their oral antidepressant, or to start getting a placebo and continuing their oral antidepressant. And the things they wanted to look at is kind of the primary efficacy endpoint was to look at the time to relapse in stable remitters. So to answer the question is, if this medicine obviously, it seems to work in the short term to help people with depression, but can you sustain that by keeping them on the medication longer? And the time to relapse, relapse we talked about would be, an increase in a MADRS score above 22 for 2 assessments, or a clinically relevant event. So clinically relevant event could be something like, a psychiatric hospitalization, a suicide attempt, or things like that. And then the secondary endpoint would be the time to relapse in the stable response group, and then a change in MADRS from baseline to maintenance phase endpoint. So in terms of the primary endpoint, so there's a lot happening here. So looking here, these are patients that were in that stable remission category, right? So patients that are doing very well. There was 176 of them, and they found that there was a relapse in 26% of these patients, compared to about 45% of the placebo group. And they found that the median time to relapse was not estimable based on the Kaplan-Meier method for the treatment group, but for the placebo group, it was about 273 days. And so they found that, the risk of relapse was decreased by about 51% in the treatment group compared to the placebo group. The secondary endpoint was kind of looking at the same thing, but in the group that was stable responders, but not quite stable remitters. And they found that the relapse rates here were about similar, actually about 25% in the treatment group compared to about 57% in the placebo group. And they found the median time to relapse for the treatment group was, a long time, 635 days, compared to about 80 to 88 days for the placebo group, so much less. And authors found that the risk of relapse decreased by about 70% in the treatment group compared to the placebo group. Another thing they looked at here that I wanted to mention is that the dissociative symptoms and the perceptual effects, the pattern was that they began very soon after administration, peaked around 40 minutes and resolved by 90 minutes, and kind of lessened over time. So if you look here, these are each treatment day. Your CAD score should be 0 when you're coming in before you get the medicine, and then you get it, and then 40 minutes later, it's quite high. But then by about 90 minutes, it's back down close to where you started. And the pattern being kind of over time, you would see a lessening of this dissociative stuff. The treatment emergent effects are similar to what they were in the shorter term study. So dysgeusia, vertigo, dissociation, somnolence, dizziness, headache, nausea, blurred vision, and hypoesthesia. And so just to summarize the conclusions, again, I didn't have as much time to go into this as you could spend, but if you're looking at patients who achieved a stable response or a stable remission after 16 weeks of treatment, the continued treatment showed a statistically significant longer time to relapse compared to discontinuing treatment. In the last few minutes, now that I've hopefully answered a lot of the questions that you guys may have, and again, we'll take some time for questions at the end. I just want to talk about, the last part is just talking about kind of our service. So, we do have the Esketamine Treatment Center here at the Institute of Living. We're organized within the Center for Interventional Psychiatry along with ECT and TMS. We started treating our first patient at the end of May. We're 2 days a week currently, Tuesdays and Thursdays. We kind of started slow, but definitely have picked up some good momentum over the summertime, and our numbers are growing, which is exciting. The staff is, the core staff is myself and our nurse, Cassandra DeMonte, who's terrific. And we are located in the Burlingame building on the 2nd floor on the southern entrance. So this is the smaller door, not the one with the big Burlingame sign. I think our patients sometimes get lost over on the other side. Our phone and fax number is here. We have an email address. We have a website. How to refer is, online referrals are submitted by generally a psychiatrist or a psychiatric APRN. We are reviewed by myself, and then consultations are scheduled as indicated. And a question I often get is, does it have to be a psychiatrist or an APRN referring? No, not absolutely. That is the preference. And the reason for that, the big reason for that is that this is a medicine that's approved as an adjunct to an oral antidepressant. So our role here is to provide the esketamine treatment. So these patients will need somebody to be prescribing their psychiatric meds, and that somebody is not going to be me. And then the other thing, which I think, we can navigate around is, the definition of TRD is highly dependent on adequate med trials. And so the person that's prescribing the medications for that patient is generally going to have a good sense of what if those have been adequate or not. Certainly, if both of these things could be mitigated, then we could get referrals from other people. So this is kind of, we have a website here. It's within the IOL website. This is kind of what it looks like here on the right. Down here, you have the referrals, online referral slot right there. Our treatment protocol, like I said, the online referral is done for screening. We review it and we schedule a consultation. Our inclusion and exclusion criteria are basically the same as the FDA approval, FDA label. The consultation, we look at kind of the vital signs to make sure those are stable enough. We look at a treatment medication history, medication list, do a MADRS to look at symptom severity. And then the bulk of it is really the informed consent, REMS enrollment, which I'll get to, and then initiating the prior authorization. And I will say the biggest barrier to moving from here to here is the prior auth process, which can be straightforward and okay, or it can be a relative nightmare. It can take a number of weeks to go from this place to this place. Another thing that can sometimes cause delays is just that, we're only 2 days a week, so it can be hard to get somebody in right away. Once we do get them here, though, they start what's called the induction phase. So these are 4 weeks where they come in twice weekly. On day 1, they get 56 milligrams. Subsequent days are somewhere either 56 or 84 milligrams. I do a MADRS, a rating scale, weekly. And then at the end of those 4 weeks, we assess to see if they've had a response, if they've improved. If they haven't improved at that point, we don't recommend continuing. If they have improved, we transition to maintenance treatment, which is weekly for 4 weeks, where you're getting either the 56 or the 84 milligrams. Again, the MADRSs are done weekly to assess improvements. At week 9, we can decide to either continue weekly or reduce to every other week, with the goal of trying to, get the least frequent dosing to maintain a remission response in a given patient. So as you can see, the patient the medicine itself is self-administered by the patient under our supervision, and the appointments are usually 2 hours and 15 minutes long, roughly, to monitor for side effects, where we look at blood pressure initially, and then 40 minutes after they get the medication in before they go home. So this is just, again, this is in the label, so you can see the dosing recommendations are basically exactly what we do. This is the device itself. Each device is 28 milligrams. So if you're on 56, you get 2 of them. If you're on 84, you get 3 of them. You take a 5-minute break in between them. And that, like you can see here, the patients self-administer. It's pretty straightforward under our supervision. So a sample appointment, looks at, like, let's say 9 a.m., patient comes in, gets the vital signs, then I meet with the patient, look at the interval history, side effects, tolerability, assess their symptoms through a MADRS or more informal. Then the medication is given under self-administered under the nursing supervision. Then vital signs are measured 40 minutes later, and then I meet with the patient halfway to assess their tolerability, because that's usually when they're going to have the peak of their side effects. And then I meet with them again before they go to assess for discharge readiness, answer questions they may have, and then we get one more set of vital signs, and then they go. So as you can see, there, these are patients that are coming twice a week or once a week, and the appointments are long. So you sort of end up with, a small group of patients that you get to know pretty well, because you're seeing them all the time and they're there for a long time. I just wanted to mention REMS. I know I want to push through, but REMS, this is a REMS controlled medication, kind of like how clozapine was. And it's a way that we can try to look at, any serious potential adverse health outcomes or abuse or misuse of the medication. So the patients have to be enrolled. I'm enrolled. This healthcare setting is enrolled. Our pharmacy is enrolled. And it mandates that the patients are monitored in a clinical setting for at least 2 hours after administration. And then after every treatment appointment, I have to submit an online form, basically just reporting side effects like sedation, dissociation, blood pressure, or any other serious problems. Just to give you a sense, of what our numbers have looked like, or what our experience has looked like. Again, we haven't been open that long, and it's just a couple of days, but I've personally evaluated 29 patients for esketamine treatment. Of the group that I've consulted but haven't started, that's 12 of them. 2 of them had a history of pretty real significant psychosis, so they were not appropriate. One patient couldn't do the schedule, another patient couldn't secure transportation, another patient, the insurance wouldn't approve it. We had a patient with a medical contraindication. We had a patient that we lined it up and we just lost contact with them. We've got 3 patients that are currently pending a prior authorization, and we have 2 patients that are pending an appointment. We just don't have anywhere to put them in quite yet. We also have some patients that have started but have since stopped, only 4 of them. We had 1 patient who had 1 dose. That's the number 1. The number is the doses they had. So we had 1 dose and felt the dissociative stuff made him very anxious and he didn't want to come back. We had another patient that had 4 doses and she got a new job, and so treatment wasn't going to work for her. We had another patient who had 6 doses and described experience of tinnitus, so he was stopped. We had another patient that actually had 12 treatments and she was doing great. Was in stable remission, but unfortunately she had an alcohol relapse, and so had to focus her treatment on that. We currently have 13 patients here. I just wanted to briefly include their general information. So, the columns are obviously, the patient, I just sort of alphabetized them from our first patient to our most recent patient, A through M, what phase they're in, how many treatments they've had, what dose they're on, what their current clinical status is, and what their dosing schedule is. So patients A and B are kind of similar. They are our two first patients. They're both in maintenance. They've had 20 and 19 treatments respectively, both on 84 milligrams. I put a star beside stable response because actually they were both in stable remission, and both of them went down from weekly to every other week and had a worsening of symptoms, and more recently are now back weekly and are more in that stable response category currently. And then I've got two other patients also in maintenance, had 15 and 14 doses respectively. They're both every other week, and they're consistently, one of them is in a stable response, the other is in stable remission. And then I've got two other patients that have had 12 doses. They're in maintenance. They're both have demonstrated a stable response. They're coming weekly. And then two additional patients that have had 10 doses. They're both in stable remission. They're coming weekly. And then I've got 5 patients that are in induction phase. A patient who's just finishing that up today, who has shown an improvement, but doesn't meet criteria for a stable response. Will be going to once weekly. And then a patient who, another patient who's had 7 doses is improved, but not technically in remission. And then 3 other patients who haven't shown any improvement yet, but are relatively early. So at this point, I think we're sort of running out of time, but I'd like to open it up for any questions that people may have.
Thank you, Dr. Anderson, so much. You had well over 130 participants, just so you know. It was quite an interesting topic. I don't know if Dr. Perlson, if you're still on, if you want to ask your question.
Yeah, absolutely. Ben, that was a great review. So thank you so much. It was very interesting. And it's a complex topic that you really captured very nicely. I just wondered, given that there's also some kind of esketamine program at the moment on the IOL campus at the clinical trials unit. I know they've looked experimentally through drug company trials at suicidal adolescents. They did a lot of the initial phase 3 work. If your group relates in some way to that group, do you interface or refer patients back and forth, or how does all that work?
Yeah, I actually met with Dr. Demakonda not so long ago to discuss how we might be able to collaborate a little bit more. We are thinking about trying to get a registry together for the patients that we have here. So, the efforts honestly lately have been more just trying to get what we're doing now up and running. But I did recently meet with Dr. Demakonda, and we would like to find additional ways to collaborate. And we do get patients sometimes that call there looking for help, and then they've directed phone calls over to us. So yeah, I think it's an important point. I think it's an area that I'd like to get more involved in, and I'm open to work with you guys in any capacity that I can.
All right, fantastic. Thank you.
Sure.
Dr. Pam Schumann was wondering if you could email out the MGH antidepressant treatment response scale. Yeah. If you want, you could email it to me, and I can email it to all of the registered participants.
Yeah, that's fine. I can do that today.
Okay. Dr. Pepper, are you on? He was next for having a question. He might already be going to CCT. His question was, have you established a criteria for discontinuation of treatment after a response?
Yeah, it's a great question. And one of the slides I didn't get to is I was sort of trying to compare the trends that I've noticed in my brief experience compared to what they've seen in research stuff. So, for example, one of the things is that, I guess just to be brief, I have not. So a lot of that, we haven't had anybody discontinue treatment yet that are in remission or response. I think that's a big kind of question that I still have, is how many patients are able to get there, and how many of them are successful. That relapse prevention study obviously shows that relapse rates would be higher in patients that discontinue. So no, I mean, I think it's going to be something we're going to have to figure out a little bit as we go. And a lot of that goes into kind of, the hope is that if someone can feel the same positive effect coming every other week compared to weekly, we'd like to get them to every other week, and you could sort of expand that as well. So I think some of it, there are some patients that, as we're getting to kind of every other week, we're thinking about what might be next. I mean, it would become kind of considered to be off label, but going to potentially every 4 weeks for a while. Because patients have a range, right? Some patients come in and say, I just want to feel better. And if I have to do this for the rest of my life, I'm willing to do that. Or another patient say, yeah, that's my priority, but I also have a lot, I don't want to be doing this forever. So my goal is to see if this helps me and then find a way to make the frequency of appointments not super cumbersome. So I think a lot of it's going to be something we figure out together. And I think we just haven't been open long enough to get many patients to like the kind of 4-month mark. And our 2 longest term patients, we actually had to tighten up the frequency of appointments. So it's a great question. And maybe a year from now, I'll know more.
Dr. Weiss, are you on? She was thanking you and saying that this was very helpful. I'm not sure if she's still on and you want to ask your question.
I'm here.
Hello, go right ahead.
Thanks, Ben. Yeah, really good. Very helpful. And good to see the actual data about who's here, how many have we sent and everything. I guess my question was about the boring stuff, Medicare, Medicaid, and private insurance. And what have you been seeing in terms of patient responsibility or cost?
Yeah, that's not, I mean, that's, I think 50% of what I think about related to this is related to that. It's a huge range. And that's why I said it's a real rate limiting step. And even within the same provider, it's a variable. Like, we've had some patients with Blue Cross who it's seamless and painless and it happens quite quickly. And then we've had other ones who it's a nightmare. I mean, I think certainly the relative kind of nightmare prior authorizations are not the majority. They are the minority. I'd say 20, this is totally off the top of my head, but let's say 25% have a very nice, easy prior auth process. And then maybe 50% have what I would consider a reasonable prior auth process that takes time, but you do get there. And then 25% have a nightmare prior authorization process that sometimes never gets you anywhere despite many hours. So it is a range. I think it's, I think I'd say probably about 3/4 of which we get there. It just might take a little bit of time. The J&J has like a cost savings program that patients can enroll in, and they'll actually really reduce a lot of the out-of-pocket costs for the drug. So if patients have are only covered by 50%, J&J actually, the cost savings card will cover up to like $7,000 per calendar year. So we've got a number of patients where we've had partial coverage, but the patients couldn't afford the copays, and then the cost savings card has helped carry the rest of the load. So it's been okay. I would like it to be a lot faster, to be honest, but it's not so bad.
And all the prior auth stuff, that's your office managing or our office managing?
No, it's us. It's because it's my wonderful nurse Cassandra who does it all the time. I feel for it. Yeah, it's us.
Thank you.
Dr. Sugarman, are you on?
Yes, I'm on.
Go right ahead. Thank you.
Yeah, so ECT has been the treatment of choice for treatment-resistant depression or the most severe forms of depression. So my question is there any thought yet, or how the on use of esketamine or ketamine is changing the formula that we follow now? Is it for patients that fail ECT, or is it prior to ECT, or instead of ECT?
Yeah, that's a great question. I think, I don't think that's necessarily something's been completely ironed out. I mean, I think that, and I don't think they've actually looked at comparing the two, like, what is more effective, ECT versus esketamine versus TMS. I think in my limited experience, I'm getting a lot of patients who sort of will say, I want to try this, and if this doesn't work, then I'm willing to do ECT. And I think maybe that's just because of how people think ECT is, and just going under general anesthesia, et cetera. So in my anecdotal experience, I think it's something that people want to try before ECT a little bit, in that because maybe it's less invasive, less frequent appointments, these kind of things. So I've definitely seen patients kind of have not tried any of the ECT or TMS stuff, and they're coming to us to start. And then I've had other patients that have maybe tried TMS and then come to us, or have tried ECT and then come to us. But yeah, I think a lot of it's patient preference, because I usually will just say, well, what do you think? What makes the most sense to you? Is this something does this make sense to you with the side effects we've talked about? Or can you get, is electroconvulsive therapy something that makes sense? I don't think one or the other is right or wrong. I think it must be patient preference.
Okay, so it's on the
Let me
menu.
just say a couple of things, Dr. Sugarman. Yes, very good question. And that's, kind of part of the reason why we have all three treatment modalities under one umbrella of the Center for Interventional Psychiatry. And that's why we do the consults. And, again, right now, Dr. Anderson is the main person. But the hope for the future is that when a patient comes for an evaluation for treatment-resistant depression, we can also explore other avenues. Years ago it was easy; it was just ECT. Now we have the TMS and Esketamine, and depending on, again, his patient's preference, as all sorts of factors. But we try to kind of work together. And if one patient is seen for TMS consult by Dr. Ruggieri and prefers something else, then we move them along to Dr. Anderson. So, but good question, very good question. And the same thing is just to mention, when you mentioned the maintenance. When do you stop? It's sort of similar to what we're doing also with ECT and TMS. We kind of, there are lots of studies, but if you look around the country or around the world, people are just sort of trying things. So you do, twice a week, once a week, extend it, and so forth, and what patient can tolerate and prefer as well. So, but thank you, Ben. That was excellent.
I think we might have just one last question with 4 minutes remaining. Carol Whelan was wondering is cannabis use an exclusion?
Yeah, I think it was in the clinical trials. To me, that's a judgment call. I think people have different perspectives on it. To me, it's not necessarily an exclusion. I think it depends on the severity of use. I think if someone is waking up and smoking every day, all day, that is more of a problem. I think, rarer use or not such severe use, I think is okay. So I sort of try to just assess how frequently they're using. Certainly, within the day of the treatment appointment or within 12 hours, I recommend, not smoking anything. But I sort of treat that one a little bit like I would treat somebody that drinks. So if somebody drinks moderately, that's okay, that's fine. But if they have a severe alcohol use disorder, they would not be appropriate for treatment. So I personally have ended up kind of treating marijuana similar to that. And a few patients I've had are actually on medical marijuana. I've started them on treatment.
And really quickly, one last question. Are the dissociative effects necessary for antidepressant efficacy?
That's a great question. No, they're not. It's a question that people ask me, and it's a question that I asked when I started, and it's incidental. Whether you have dissociative effects or not seems to have no bearing on whether it will help your depression. So no.
Thank you so much, Dr. Anderson.
Excuse me, Dr. Anderson.
Yeah.
This is Dr. Olufa. I just started at the older adult unit. Now, one of the criteria is that the patient should be 64 or under, which excludes all the older adults. Is there any reason for this?
Yeah, so some of it is that the FDA approved that age group, so it's got FDA approval for 18 to 64. One of the other studies that was done there, they basically replicated that short-term study I reviewed, the flexible dosing 4-week study. They looked at patients that were above 65 and older, and they found that there was an improvement, but it did not separate from placebo, so it never ended up in the FDA label. Does that mean it wouldn't help an older person? I don't think so. And so I've had one older patient where the insurance company said they wouldn't pay because the patient was 66 years old. And it's not FDA approved, but I've had a couple other patients that are in their kind of mid 60s that we've been able to start okay and have done okay. So I think It's not in the FDA approval. I guess it's technically off label, but I'm okay treating some patients that are a little bit north of 60, 65.
Thank you so much, Dr.
Yeah.
It was very informative. Thank you so much.
Yeah, thank you.